So our next topic is supporting restorative therapies in the post-acute care settings. We have Jessica Cook, Lisa Haas, and Kelsey Storm. So Jessica has been a physical therapist for 13 years and stroke certified since 2015. She has fulfilled many roles in the healthcare system, from acute care to outpatient, and finally, in her area of passion, inpatient acute rehab. Then we have Kelsey Storm, works at Benefis Health System in both the inpatient and outpatient rehab settings, specializing in post-acute stroke and brain injury rehab. She strives to provide therapy focused on patient-centered goals and real-world application. She enjoys educating families of patients with brain injury, as well as advocating for the speech therapy profession, and is a medical setting representative for the Montana Speech Language Hearing Association. She has also created curriculum for nursing assistant trainings during the pandemic, holds a certification in the Parkinson's Voice Project Speak Out program, and is FEES trained. And then Lisa has been a practicing occupational therapist for the past 15 years. In her years of employment, she has worked acute rehab, inpatient acute rehab, outpatient pediatrics, and senior services. Lisa has completed IFRA certification, and the bulk of her OT experience has been servicing patients in the acute rehab setting, focusing on post-stroke recovery and maximizing in-depth with occupational engagement in daily life. She has completed specialized training to service all qualifying diagnoses. Welcome to the three of you.
All right. My name's Jessica. Thank you so much for having us today. Just want to do a little plug. We come to you from Benefis, which is located in Great Falls, Montana, kind of centrally located. The three of us, and then there's a few other members in the audience from Benefis as well. But we work primarily in an inpatient rehab setting. Our setting is 20 beds. We're very fortunate to we can kind of check off the list everything that was described earlier. And so we're excited and actually probably interested in joining that program. But we get to every day kind of work in that interdisciplinary team with physiatry. We have a hospitalist on staff, clinical psychology, social work, and then, pharmacy, dietary, kind of all of those people as part of the Benefis proper. Most of our patients do come to us from the acute medical setting at Benefis, but we do accept regional transfers. So for all of you out there looking for a place for your patients to go post-stroke, if you're in a more rural setting, Helena, we take a lot of patients from Helena, Browning, critical access hospitals, kind of north of us, Havre, that area. We're more than happy to take those referrals. So just a little bit about us as well. And thanks for the introduction. And I was really pleased. We were going to actually pull the audience as well to kind of see who we have for participants. So it's really great to see the width and breadth of what we've got here today. So we'll go ahead and move forward. So we're going to be kind of coming at you from three different angles. I'll be kind of going over some physical therapy specific concepts, but kind of just some broad concepts about recovery models and things that we, or me and my colleagues, look for and kind of work with our patients. I'm going to be talking a little bit about neuroplasticity. It's never too late to be changing the brain and doing some exciting things with your patients. And then things that anybody can do, just activities that you can continue to do to facilitate those goals for your patients, even months post-stroke. And then Lisa will go into some independence, IADL activities, bilateral integration, and just activities you can do for increasing awareness of the affected side. And then Kelsey has a great presentation, things and tips and tricks for swallowing language, having conversation with your stroke survivor, and cognitive considerations. So just kind of give you a holistic approach here. All right, so for the therapists in the room, this may be some redundant information, but for all the other areas, including nursing, these are just some of the the big picture ideas when I'm assessing a patient or when any one of us are assessing our patients, we're kind of thinking and keeping in mind these general rehabilitation models at the forefront. So obviously the gold standard is that restorative or remediation type of therapy, kind of getting right at the affected issues, the impairments, and hitting it straight on and giving the brain stimulus and creating change for our stroke survivor. So restoring that lost function. And I think when we speak with our stroke survivors, that's kind of what they're asking for us. They want to be how they were before the stroke. They want to look that way, they want to walk that way, they want to talk that way. We all know from experience there's still going to be some underlying impairments, but that's the end point, that's usually their goal in whatever it is. So that's kind of where we hit hard. Fortunately, we can kind of take advantage of that in an acute and an inpatient type setting. Get in there right away, first 48 hours, and kind of be pushing hard. The next that I'm describing here is adaptation. It's a type of rehabilitation. We see it a lot more maybe in vestibular type activities, but really what you're doing is trying to get the brain to adapt to different types of signals. So that's just one, that's kind of a breakdown version of it. The next is habituation. So if I continually stimulate the brain, if my patient is fearful every time they turn to the left, their weak side, when they go into the bathroom, but I practice with them that turning to the left, I'm habitually decreasing that fear response for that activity. So that's another type of rehabilitation. Maybe not technically restoring lost function, but just getting them used to a new way of doing an activity. And then lastly, compensation. So this is not a place I like to go to right away, but we all have had to get there at some point with our patients. If they're really weak on one side of the body, you're going to have to do something to compensate away from that impairment. Again, not something I want to do right away, but you'll notice your patients will naturally do that. If their left arm is weak, they're going to use their right arm to get dressed or feed themselves or things like that. And what we really try to do is come at them hard to make sure that they're using their affected side. I brought with me today a hemi walker, so if I'm a patient that has weakness on the left side, I had a right brain stroke, what you'll often see probably in your settings is they stick that hemi walker, your therapist will stick a hemi walker on the right side and have them start walking like this. They're not using their left side, and so I would say this is more of a compensation technique. I'm not engaging the left side at all. I'm not having them weight bear on their leg. I'm not having them engage and use their left arm in swing phase. I'm just kind of getting off of it, weight bearing away from it, and having my patient walk around. So if they're really weak, I'll even maybe use a platform walker or a front wheel walker instead, just to try to get their upper extremity engaged, get them weight bearing more equally on the weak side. So exciting things. Any of us that take care of stroke survivors can help the stroke survivor's brain reorganize. So tons of research out there. I know neuroplasticity, maybe you've heard about it, maybe you haven't, but there's a lot of exciting research out there that neuroplastic changes don't just happen in development, they happen after any type of injury. If you give the brain the right type of stimulus, positive or negative, the brain will change in response to that stimulus. So there's a lot of new studies coming out. The thing that kind of caught my eye is that research is showing even 10 minutes of an activity, dendrites can grow and create new connections between the neurons with the activities that you're doing. So really, really exciting. I think one tool that they're using sort of to measure that is that functional MRI, which some of you may have in your clinical settings where you work. The other thing that just a little plug to my further slides, but things that kind of facilitate neuroplasticity that might not just be the activity or the therapy. There's new research on music therapy, exercise, healthy diet, sleep, and decreasing stress. All of that prepares the brain for the neuroplastic changes that you're trying to induce. So again, when we're talking about neuroplasticity, I just wanted to give you a little visual. So we've all probably seen this, and if you attend tomorrow, you'll probably see similar pictures to this. But this picture is showing the infarct core, so where the most damaged part of the brain happened at the level of the stroke, and then the area around that called the penumbra. So within that first 48 hours, that healthy tissue, that penumbra that's still maybe slightly affected, there's some inflammation there, but there's still that collateral blood flow. That brain is attempting to kind of make those connections and reorganize there. And so that's why those AHA recommendations are saying hit your patients hard early on. There's changes happening, and we want to make sure that we're not losing anything else. In the following weeks, there's still recruitment of the cells, synaptic plasticity, and things going on. And then I think the thing that's exciting for all of us, especially when our patients maybe start to slow down a little bit, is the brain can still continue to remodel itself. It's never too late. We can still induce change, however small it might be, but we can still kind of keep working toward those end goals for our stroke survivors. So I know this slide is kind of busy and the writing is really small, but it's just, I'm going to go through each one of these things briefly. Some of the neuroplastic principles and things that you can do to work with your stroke survivor. So the first thing to kind of get at that brain change is motivation. So is the stroke survivor interested in what I'm having them do? Are they engaged in it? Is this a goal that they picked, or is this something that I picked for them? Do they care about picking up cones from the table, or are they more interested in being able to pick up the telephone to call their granddaughter? So picking an activity that really motivates them, that will enhance those neuroplastic changes. Intensity and challenge, I know that was, we talked about that a little bit earlier. We don't want to go too light on them. And there's actually a lot of research about high intensity interval training. I'm not going to go into that too much here, but you can see that out there in the literature. There's new stroke programs out there that really kind of hit on that form of training. But is the activity hard enough? And I'll show you guys kind of how to measure that in a few slides. But too much difficulty can inhibit learning. They can never be successful in the activity, so it's a little bit too hard. But I want them working really hard, having a little bit of a sweat. Whatever variable I need to adjust to get them to be able to complete that activity and make it kind of fun in the meantime. The concept of use it or lose it, I think we've all heard about that as well. So if I put a flaccid limb in a sling and never have them use it, I'm not stimulating anything in the brain, and they're not going to be using that limb. So it can be a negative concept as well. If they're sitting in a wheelchair and a recliner all day and I'm not having them move like I want them to, again, not stimulating the brain. Repetition, like shooting a free throw. I'm never going to get good at shooting a free throw if I don't practice that activity over and over and over and over. So repetition is important for brain change. Salience, kind of this goes back to that concept of motivation. Is this thing that we're doing important? Is this a goal that they've identified to complete? Age, research is showing that a younger brain tends to adapt more quickly and readily and be kind of open to those changes. Sleep, a lot of new research. I included an article here. I have more research too, but deep sleep, there's things that happen while you're sleeping that kind of put into place those neuroplastic changes as well. Measuring success. So it's kind of fun thing to do with your patients, gamify it. Don't just have them walk 10 feet. Say, you were able to walk 10 feet in 60 seconds today. Our goal is we're going to get that down to 40 seconds. And be timing them. Has anybody here heard of the CIRO study that they did in inpatient rehabs? Nope. So they took 184 stroke survivors. This was in 2010. Divided them into two groups. One group, the usual therapy, walked about 25 feet every day with their therapist. Didn't give them a lot of feedback, just maybe good or whatever they needed to do, increase heel strike or stride length or anything like that. But the second group did the same thing, but timed them every time and then gave them that feedback. Oh, you did that in 30 seconds. Oh, today you did that in 25 seconds. What they found on discharge is their walking speeds were significantly faster than the control group, and that they maintained those gains 3 months post-discharge. So kind of a cool easy little thing, just adding a timer to whatever activity. It increases the challenge, it gets them having fun, and they're kind of make it a little game for themselves. The next thing is autonomy, so letting them have a choice in the task, where you do the task, how difficult the task is. When we talk about RPE, which is a way to measure intensity, let them pick what level of intensity and see if they can achieve that. And they can't, then you can adjust your goals accordingly. Expecting success. You don't want to make things so hard that they're believing in them that they're never going to be able to achieve that. So you want them to be able to win or achieve that goal every so often, so that they kind of get that feeling, oh, okay, that's what success feels like. That's what that feels like when I can complete that activity. And then just knowing your patients. We all know every single stroke survivor is different. Some would be super motivated by gamifying an activity. Some, that just does not make them go at all. So kind of understanding their personality, and then kind of gauging your treatment to that. And then lastly, I have to talk about aerobic exercise. So there's a lot of research out there, and we'll talk about that a little bit later. But keeping your stroke survivor active, even if you don't feel comfortable doing these specific, therapy type activities, just getting them into some sort of home exercise program is so great. Not only does it reduce stroke risk factors, but they're finding that brain-derived neurotropic factor kind of enhances, again, those neuroplastic changes when people exercise. So why do we care about walking speed? Has anybody seen this chart before? My PT over there. So this is a walking speed chart, and why walking speed matters. This came from the paper, the sixth vital sign. Walking speed is considered the sixth vital sign. And you can measure that with just a 10-minute walk test, but people who walk faster are less likely to have risk of death, hospitalization, fall. They find that people that walk faster have increased independence and self-care. They can be a community ambulator. They can get across the street. It kind of is a little breakdown to ADLs and IADLs that we don't even think about. So just a little plug for the physical therapists out there. That's one way to challenge your patient. Yes, my patient can walk, 50 feet, but how fast can they walk? How safe can they do it? And can we get them walking more quickly and more safely? So which model is best? I would just say, as I've been saying, I wouldn't just automatically jump to a compensation technique or substitution. I wouldn't just say, oh, they have impairments here and here and here, so we're not going to challenge that. I would say you challenge the system. You're not going to get it better unless you challenge it and give them the stimulation that you need. I would say, even if with some of the techniques, help them become less fearful. What is the thing that is driving them to sit in their wheelchair all day? Is it depression? Are they fearful of turning? Actually, I was going to say one thing. There's a really good article that just came out on psychiatric symptoms after stroke that I read and shared with the team at Book Benefits, if anybody wants a copy. But it was in a psychiatry journal, so might not be on something you subscribe to, but it was great. And then helping them to sleep more. That also can help with mood stabilization and also, again, neuroplasticity, and then becoming more active. Asking your patients, what do they want? What are the goals? What activities are important to them? What did they lose after they had a stroke, and what do they want to get back? Maybe it's not going to be the same exact thing. They love to go work out, but I can still get them on a new step even if they're not able to run anymore and get that aerobic fitness going. This is the RPE scale that I referenced earlier. It's a way for you to measure the challenge for your patient. So I want to stay out of the light and very light, and I don't want to get really in the very hard area. So if it's too light, there's no neuroplastic changes. If it's too hard, same difference. You kind of want to be in that highlighted area somewhere in the middle for your patients. And you give them this scale, and they pick the number for you and they tell you where they're at, just similar to any other scale, like a pain scale. So lastly, activities that you all can do, just kind of as a recap. So we talked about sleep hygiene. When do they sleep? How are they sleeping? Are they napping through the day and they're not getting a nice, good rest at night? Set up some sort of home exercise activity or a strengthening program. It doesn't have to be something fancy. You could literally set up 2 chairs, have them do 5 sit-to-stands, walk to the next chair, 5 more sit-to-stands, a little mini circuit training for them. I include the picture here on the right, here in Butte, across the way. There's a little outdoor walk path, and they have these little outdoor strengthening things that I played on with my daughter here last summer on. But I thought, what a great way. The patient can't afford maybe to have a gym membership, but I can take them to this and we can walk together and then stop and do a little bit of strengthening activities together. Again, it'll kind of help with the mood stabilization too. So if your stroke survivor is having a lot of depression, that exercise can kind of help with that as well. Getting them out there may be a trick, but research is showing that that's good for that. Measuring how hard they're working and making sure that they're continually challenged, and then making sure that you're engaging them with things that they're really interested in doing. So with that, all right, I'm going to turn it over to Lisa.
Hello. So I think as an occupational therapist, I have to talk about ADLs and IADLs. It's just a requirement. So when somebody's had a stroke, at least for me, I'm going to be honest and confess, there's a lot of pressure. You want this person to get better. And in that can come this, you want your therapy sessions to be new, you want them to be innovative, you want them to just really find each moment so great. But that's actually contraindicated to the research. We're actually finding that having a lot of repetition and doing familiar tasks is actually what's going to maximize their recovery. So of course, ADLs, everybody does it every day. I kind of call OT what you do every day and you take it for granted that you could do it. So what we really need is for people to be able to get back and engage in their daily activities of life, including ADLs and IADLs. And as she was saying before, this maximizes neuroplasticity, and it also does a maximum benefit of using muscle memory. These people are naturally always doing these tasks, so we're using muscle memory that was there before this stroke even occurred. So the one thing that we need to really keep in mind post-stroke is that one thing that can be really difficult is new learning. So if we're constantly introducing a new activity and new learning every single day, we're actually not benefiting or maximizing this patient's recovery. There's a lot of benefits for doing ADLs and IADLs. So those benefits also include increased body awareness. Half the time after having a stroke, someone only has good awareness to one side of their body, and they need to be engaging their body as a whole, and doing ADLs is a great way to do that. We also need to address balance. Somebody sitting edge of bed that can't sit up by themselves is going to really struggle to get a shirt on. So we need to make sure that before we really start to do the ADLs and focus on maximal independence, that we also address balance. Really good things to keep in mind is just body posture. I think we take for granted how somebody sitting with their legs crossed can almost create a balance beam with your balance. Simply changing your base of support will immediately make someone safer in sitting. If somebody's falling over while sitting, are their base of support shoulder width apart? Do they have a good body posture? Just fixing their feet can automatically improve their balance. So just be really mindful of that, okay? And then obviously strengthening. I love that concept of the more you do, the stronger you get, or that use it or lose it thought process. So the more you engage in your daily activity, the more this person's going to get stronger and actually just be able to increase that daily activity tolerance. I like to try to think of somebody post-stroke as like a gas tank. And what happens is each day they only have so much gas in that tank. And what happens is the less they do, the less gas they have in that tank. So we want to make sure that as we're engaging in daily activity, that we're using the right kind of gas, the right kind of hard with that RPE scale that she was mentioning. So when you're doing your ADL assessment or you're having someone engage in their daily activity, what can be an issue is sometimes somebody uses 100% of their gas by 10 a.m. in the morning and they have nothing left for the rest of the day. So we want to really make sure that what they're doing is the right kind of hard. So if they can't fully do the task by themselves, we want to have them do as much as they can independently and then only help as needed. And then I have to say, the greatest concern is learned helplessness. What we don't want someone to do post-stroke is to learn to be helpless, that they just don't even attempt to do these tasks anymore for themselves. And this is where family training is really vital. It's so easy for somebody to love their family member and they've had a stroke, and it's so hard to see them struggling that they just want to do it for them. And that's actually kind of the worst thing they could do, is just constantly just do every little thing for them. And we as caregivers need to be mindful that we're not subconsciously doing that ourselves, that we're not even giving somebody the opportunity to do something themselves that they could readily and easily do. So the one thing with ADLs and IADLs and all of these engagements of purposeful activity is the point that you have to understand that it will take more time, and we need to be patient. So we can't always rush through things, and we need to make that person feel like they have all the needed time to do this task as independently as possible. So with that, we need to have increased awareness of the affected side of the body. So oftentimes when somebody is post-stroke, and let's say their left side is affected, we can really see the implementation of negative thinking and negative self-talk. And that actually is the number one kind of shooting yourself in the foot way. Because have you ever gone to a test or a sporting event or whatever, if you immediately enter that with a mind frame of, I can't, are you going to be successful? No. So we see that a lot with the stroke population, even in their way that they reference them to themselves. So what we don't want is language like my bad arm, my good arm, my strong side, my weak side. We need them to see their body as a whole, and we would want to encourage language that really facilitates that. So what we really want to do with these patients is encourage a can-do attitude and really maximize what they can do. What I really love to do with reframing someone's way of thinking post-stroke is I want them to think about what they could do day one from after their stroke and focus on every gain they've achieved since that day. We really need to maximize and have them bite into what they're doing. And that's a great thing with occupational therapy and with doing repetition. The more you engage, the more you encourage both sides of the body, the more this person's going to bite into or be motivated to do what you're asking them to do. Another really important part of this piece is that having a really good home exercise program. What I don't want a patient to have the mentality of is I'm only going to work on this when I'm with so-and-so. We really want to say that this is something you need to do every day. So in the concept of using your arms, I'm a talker and I use my arms. But when you're using your arms, how many times do you use them throughout the day? All day, right? I often see people go, well, when I have a home exercise program or you're giving me something to do at home, how often should I do it? Well, the truth is as much as you can possibly do it, right? When you have the energy and your gas tank is there, you want to continue to do those home exercise programs or whatever activities we're giving this patient to do. So implementing the affected arm, also we want to make sure that we understand that you can use your arm even if it's hemiparesis or if it doesn't have any movement at all. They should still use it all day, every day, all the time. And the worst thing we could do is normalize that compensatory strategy that was mentioned earlier where you just immobilize. We don't want to normalize, immobilize, right? What we want to do is use it at all times. So I just gave a few short examples, but when you're feeding or using self-feeding, use the affected arm to brace the plate so that when you're scooping food, you're actually holding that still. Or for hemi-dressing techniques, like in the slide before, I've got a piece of hair I gotta fix, it's driving me nuts. Sorry. Okay, so in the hemi-dressing technique that I had in the photo before, you could use the unaffected side to brace your clothing items. And actually for outpatient goals, weight bearing with the affected side is vital, and we want to include weight bearing or incorporation of the affected side as much as possible. So the patient throughout the day is going to tangibly make goals of how they're going to use this arm throughout the day. And then the one thing that you could do is if they have a really good functioning affected arm, they could use the other arm to brace while they use the other arm together. So we want to always increase this overall whole body awareness. We do not want them to have the negative thinking with their arm, and we want a can-do attitude. So with that, we also need to include and really facilitate bilateral integration. So post-stroke, our arms are always used together in a bilateral way. But post-stroke, all of a sudden, it's like there's this middle of the line wall because of our midline, and we use our arms in a unilateral way, which actually is not how we function. How often do you use just one arm all the time? Could you imagine having an arm tied behind your back all day and how much that would affect your day-to-day life? So we want to really incorporate and normalize using your arms together for coordinated tasks. So one of the main barriers with normalizing or using bilateral integration is people who cannot cross their midline. And this can be something that clinicians can almost neglect to assess or be mindful of. So that midline is that line in the middle of your body, and it can become a barrier that your one arm cannot cross. And what you see with this is a lot of compensatory strategies. People, without realizing it, they're not intentionally trying to make it something that they're doing, but they can hide this really well. So a really simple way to assess crossing midline is like, can you clap your hands and cross your midline? Well, if I'm gonna just do this simple assessment, if somebody can't cross midline, what they'll do is they'll clap their hands and they'll rotate their trunk, and then they will give you a high five, and you'll see this huge overcompensation with trunk rotation with somebody that can't cross midline. In the past, I've had somebody that it was so severe, it was like there was a wall in the middle of their body and they could not cross it. So that is a huge goal with doing crossing midline, is making sure that when you want to focus on bilateral integration, you don't neglect to assess this. And there's also so many benefits with doing bilateral integration tasks, using your hands and doing things that use both hands at the same time. So you obviously are going to have the benefit of increased coordination, hand-eye coordination, functionally using your hands together, increased awareness of the affected side. You also can work on sequencing. So if a step-by-step task, you need to be able to sequence and plan and cognitively motor plan what you're going to do. And as I said before, you have an increased midline awareness and your ability to cross midline. So with those balance deficits, if you can't cross midline, that's going to be a co-contributing, it's going to make it more complicated and complex. So we need to address balance and the ability to cross midline, and then really dive into bilateral integration, okay? And then the other thing that I love is that we can have measured ways of assessing activity tolerance. So how much activity is this person tolerating on day one, and then compare it 5 days later to assess improvement. So we really want to make sure that we use the body as a whole, that we have positive language that encourages that, and also we want to make sure that we use arms in a bilateral fashion more than unilaterally.
So I'm going to wrap us up here talking about a few things related to speech therapy. So I can't talk about stroke patients without talking about swallowing impairments. Average rate is greater than 50%. The American Heart Association, when I was preparing for this presentation, rates it at least 78% of stroke survivors have some sort of swallow impairment after their injury. Why I want to talk about this is because I feel like the assessment portion of this is somewhat misunderstood, the difference between a screening and an assessment. So obviously swallow screen is best practice for all stroke patients. The Yale is what we use at Benefis. It's actually now validated for post-acute settings as well, and I've included that in our references for anyone that's interested. Nursing typically completes this screening. That's what's done at our hospital, but that doesn't mean that that's the case for everyone. And then if there is a sign or symptom of dysphagia, then a speech therapist would be ordered to assess. So there is a difference, however, between what a speech therapist does at bedside and what is available to them in an instrumental assessment, such as a FEES or MBS. We don't have x-ray vision, so there is only so much that you can do at bedside, and that's very important. Just this last week, we had a guy who, you would have never thought that he would be safe to eat, and we decided to do a swallow test, and sure enough, he was nearly on a regular diet. So this really is an invaluable tool. I know it's not always available in the rural settings, but to the very much extent that you can provide that to your patients, it's truly very, very important. So from this, we can get diet modifications, but we can also get behavioral modifications, environmental modifications. How much supervision do they require? And are there any special equipment or anything that they might need to be successful with their eating? So if you remember nothing else that I say in this presentation, this would be what I would want you to take home. So the main objective of a speech therapy plan of care is not to eliminate aspiration at all costs, but to assist the patient in meeting their nutrition and hydration needs in the safest way possible for the longest amount of time. So historically, the first modification that we've gone to has been changes in their solid or liquid consistencies. However, that is not necessarily always what's best. There is a case for diet modifications. If the patient is overly fatigued by the end of the day and they can barely eat their meal because it's too hard to chew, they aren't meeting their caloric needs. Ease of feeding, right? If you only have one arm, yes, we want to encourage you to do both, but at the end of the day, you still need to eat. So if we can cut up their food so it's easier for them to eat, that is beneficial. There's reduced risk of buccal pocketing with dry foods. However, there's a lot of risk associated with diet modifications as well. Puree food, for instance, roughly cuts nutrients and caloric intake in half, right? We have to add half water to a carrot to make it a pureed carrot. That person needs to eat twice as much to get the same amount of nutrients, and oftentimes that simply just does not happen. Lack of enjoyment with eating, which is the biggest one in what I see, lack of interest, reduced intake. Jane Reynolds, where is she? There. She will be talking later about just thickened liquids in general and the risk of them. So that will be very beneficial for everyone here as well. It's something that I need to remind myself of as well, when that's not the first thing we want to jump to. So diet modifications have their place, but they're not meant to be a long-term solution. So what can the interdisciplinary team do to help people with swallowing impairments? The biggest thing is to assess the person and the environment before assessing the food. This person-centered care. The worst case scenario for me is when I walk into a room and a patient hasn't brushed their teeth for 3 days. They're eating their meal in their bed alone with their legs propped up in front of them with the TV on. There's so many things in this scenario that are going wrong without even addressing what they're eating or how they're eating it. So what is their environment like? If they're home or if they're in more of an IRF or TCU setting, what is their environment like? How much supervision do they require? Because if all they need is someone there to remind them of something, they might not need a diet modification. What is the furniture like? I just worked with a guy a couple weeks ago who, glad I asked because I don't always ask, he eats his meals reclined in a recliner, like all the way back. And had I not known that, well, no wonder he can't reach his food and why he's having a hard time, keeping it in his mouth. Patient and family preferences is huge. The cultural considerations for how they eat. Do they eat as a family? Do they eat alone? What is their cognitive status? Are they having pocketing? Are they having that anterior loss while they're eating? These things are all very important to assess and something that anyone can do regardless of who you are when you're working with stroke patients. Also, just following the speech therapist treatment and recommendations. I don't take recommendations lightly when I request somebody do something a certain way. And thickened liquids and chin tucks are not universal recommendations. Specific recommendations are specific for that reason. My nurses out there, I always appreciate when nurses play up the food. If there is a diet modification or if there is something that needs to happen to make that person safer, when a nurse helps the patient uncover their food, tells them, what it is, how good it smells, do you want salt and pepper, versus, oh geez, more pureed food. There's such a difference in that presentation and how the patient, takes that. I know this might not be the most appetizing thing in the world, but you need this to get stronger. You can do this. I believe in you. I'm going to help you eat this meal. I think that's really important and something I really appreciate. So we're going to do some defining of terms. I'm not going to spend too much time on this slide for sake of time, but aphasia, difficulty with language, dysarthria, motor movement or weakness, or memory. So oftentimes when I hear patients, family, staff describing communication or cognitive issues, you often hear terms like word salad, or you hear, I just can't understand them. And what I would really encourage everyone to do is describe instead of label. So how can we describe what we're hearing? And how can we describe that to the patient's family member when they call to check in on their family member? Going through each of these, the patient is aware of the date but cannot say it correctly. More of an aphasia. The patient is hard to understand and is mumbling at a low volume. More of a dysarthria or motor speech impairment. I can understand the patient, but they keep saying it's 1988. So clearly a memory impairment, right? We've learned so much more about that patient by describing them instead of just labeling. And that's very, very useful for the patient as well, to hear what they're doing well, but what they also need to work on. This is something I was requested to speak on, so I'll spend a little more time on this. I believe it was Joni, made the comment to me that oftentimes when a stroke patient is in a facility or being seen by home health staff, they have somebody to talk to that understands their impairments, and they have those people that aren't nervous to speak to someone with aphasia or some impairment. But then when they are discharged from our settings, or maybe don't have a lot of family support, their social isolation increases dramatically. This is so big for depression and anxiety, as well as just motivation to get better and to continue and to improve. So this is something, what I have on these slides is an adaptation for more anyone can do. If you're working with a speech therapist, you might do some more specific things. But how I have this arranged is the intervention on this left, and then is it the person with aphasia or the communication partner that's mostly responsible for carrying the load with each of these. So the first one, and I put it first for a reason, reducing, correcting, or teaching behaviors. It pairs very well with the next one as well, reducing asking for known information or test questions. When someone walks in the room and goes, "Who am I?" It's like, well, they know who you are. I don't really know why you're asking the patient that, because they can't say your name. That's not a useful tool, and it doesn't make the person with aphasia feel good, but also it doesn't help them. So what can we do instead? We can give them the information. There's no such thing as cheating when it comes to communication. If you are able to provide a piece of information to a person and they can repeat it back, they did it. They did it on their own, and then they were successful with that. So instead of asking, what is the date? What is your dog's name? These flashcard style answers, just engaging them in more holistic conversation. Reducing asking them a question if you know that they're not going to be able to say the answer, and working with your speech therapist to figure out how to help that person. Teaching repair of communicative breakdown. The responsibility rides on both the person with aphasia and the communication partner in this one. Again, something you might learn with your speech therapist, but also just that encouraging of how, when the conversation breaks down, don't letting it stop. It doesn't need to stop there, it doesn't need to die. Reduce the restrictive discourse behaviors, those closed questions. How was your day? Was lunch good? It's not a very conversational way of communicating. Yes, sometimes it's necessary. You want to just talk to the person, especially if they have severe communication difficulties. But on the whole, we want to increase the more open-ended questions in a way that they can be successful. Increasing the minimal turns, not just letting 2 conversational turns pass and then stopping the conversation. The communication partner is the responsible party in that one, as well as reducing interruptions. This can be outside interruptions, but oftentimes people interrupt themselves and they don't even realize it. How was your day? Did you have any therapy today? Oh, I talked to so-and-so. And it's like, holy smokes, which one should I respond to first? As a person with a communication or cognitive impairment, that's a lot. It's a lot to get hit with. So choosing just one question or one point of conversation and speaking on that before moving on. Improving self-repair is the person with aphasia's job, something they would learn, not something that they should know how to do, but that it's not always someone else's responsibility to help them say what they want to say. Increasing the initiation of questions, taking turns, participating in conversation, pairs really well with the next one, the increasing self-advocacy and confirmation of accuracy. This is one of my favorites. I often encourage people to disclose their medical condition if they're comfortable with it and it's appropriate, whether that be to family and friends, whether that be to a coworker or manager at their job. It's not required that you disclose your medical conditions, but oftentimes when you do, you find that there's a lot more support, or people that understand, or people that will say, oh my gosh, my uncle just had a stroke, and you automatically have brought that person into your circle. Confirmation can be used at any time. The conversational partner can confirm that what the person with aphasia is saying is correct. Yeah, keep going. I got that. It gives them that encouragement to continue. And I often encourage my family members to not jump in if the person with aphasia doesn't want them to. So I'll usually teach for the person with aphasia to look at their conversational partner, and that's their cue to kind of pick up the conversation. But don't jump in for them if they don't want you to. Summarizing when conversing with unfamiliar listeners. This one's really important for helping patients kind of save face, or if they're embarrassed about their difficulties with communication. If you as the communication partner see that that person is faltering and they kind of look to you, just kind of providing a natural summary of what was just said. Oh, that's right, we did do that. It was a great time. We got to see so-and-so. And you've kind of naturally taken that conversation over without making that person feel badly that they couldn't continue. Increasing that multimodal or total communication, encouraging use of pointing, gestures to the person with aphasia, but also encouraging, using that yourself. Would you like hamburgers or hot dogs for dinner is different than would you like hamburgers or hot dog? And then if they can't say which one, they can point to the hand that you lifted. And so that's a way for them to communicate with you without needing to say anything, because you have chosen to use more hand motions. The last one is just using strategies for revealing and acknowledging competence of the person with aphasia. This one's obviously very important. You can provide leading questions, or clarify what they just said. Oftentimes people don't know what to do when someone's trying to say something to them and it breaks down. And, it's like most, I think, of us in here in this room know that we shouldn't just nod and smile, but what do you do? And I think, it's hard sometimes, but I think also saying, I know that you know what you want to say. I heard you say this, but I don't think that's what you meant. You've given them that grace that, yes, you do have, the ability to do this. You are an intelligent person. I believe in you, but what you said didn't make sense, and that's okay. We're gonna figure this out. Being very practical about it, but also revealing that they have competence and that they can do this. So our second to last. This actually comes from a TBI. This was originally created for use with TBI, but I find it to be very useful. I'm going to not say her name correctly, but Mary Lou Akimovic. Limited capacity model is what this is called. So I use this a lot when I frame education for family members after stroke. So on the left is our healthy brain. It has more reserve. There's more space available for when they need it. If they're having a stressful day, those emotional demands increase. If they are having a more physical day, those increase, so on and so forth. Post-injury, your reserve shrinks. So if you have less reserve, there's more demand on the brain as a whole. And that's why things are hard. Oftentimes you'll hear people say, why is this so hard? I can't figure out why I can't do this. This is so easy. What's wrong with me? And it's very easy to explain, and we should explain this, but especially to family members who are going to be taking over for the care of this person after they leave. They need to realize this person with, after stroke is not doing this on purpose. What can we do to improve this? Sleep. This has been spoken of several times already. Taking frequent breaks, eating enough calories, especially protein, making sure that their mood and is being addressed either with medication or some other way. So to wrap this up, it's really difficult for me to speak in general terms about cognitive impairment after stroke because so much of this depends on their prior level, but also who they are and what their goals are. Someone that has 10 family members is going to have different goals than someone that's living alone. So, but when I was thinking about what I could say about this, we can all, everyone here can help ensure a safer discharge with these things. So can they write and say their demographic information? This is important just for independence. Can they fill out a form? But also, can they call 911 if there's a problem and tell them where they are? That's something we should be practicing before they go home. Can they call or text as determined by their premorbid level of function? Can they manage their medications? The pharmacist in the room that had spoken earlier, I really appreciated that because my mom is also a pharmacist, and I often tell people, managing medications is more than just picking them up at the pharmacy, right? They need to know how to use a pill box. They need to have someone to call them 2 or 3 times a day to remember to take them if they're not able to on their own. Oftentimes, pharmacists are the ones that are catching those drug interactions, those side effects that a doctor might not have time to look into. Pharmacists are much easier to get a hold of generally, and always willing to help. So encouraging people, yes, call your doctor, but also call your pharmacist. If you have questions about your medications, they're an invaluable resource. Can they pay their bills? Most people either fall on one side of the fence or the other these days. Everything's online, or they do everything on paper. So doing those maybe not functional activities for bill paying. Can they write a check? It doesn't matter if they don't write checks at home. Do they remember their password to get into their energy account to pay their bills? That's very important. Or do they have a family member that can do that? Do they have a practical, specific plan for managing their appointments? Follow-up appointments are vital. Sometimes it's hard to get into these people, and if they miss their follow-up, it might be really hard for them to get in again. And lastly, just how is their awareness and their level of concern about their home responsibilities? In general, if someone's concerned about how they're going to do at home, I feel better about that person. If they're not concerned, I'm like, oh, it's going to be great. I'm not going to have any problems at all. That's a red flag, right? And so if your patients are saying that to you and it's like, well, there might be some reasons, to have a little concern. Those are the people that you want to work a little bit more with to make sure that they know that yes, you have, you're positive about their recovery, but there's also some things that they need to look out for. And so that is our presentation. What questions do you guys have for us? Yes.
I have kind of a 3-tiered question about motivation. So how do you motivate somebody when you really can't find any motivation or they don't have any motivation? How do you continue motivation when their therapies aren't actually having them get better, but they're just trying to maintain not losing any functionality? And then I guess what is the dropout rate for these patients that really don't have motivation with their therapies? That's a lot of questions, but
I'll speak to the first one and then you guys can do the other ones. Okay, so as far as finding motivation, they also have likely some ideas, but I think for me, for adults, we have to have goals. We write goals for our patients, or we have goals for them, but if they're not a part of that process, and if they're not the ones setting those goals and actually I'm talking like putting them down on paper. That is something frequently that I'll do with, not everybody, but like the people that you're just like, oh my gosh, I care more than you do about you getting better. Okay, you're leaving this hospital or this rehab facility, you're not going to see me an outpatient forever. What do you want to be able to do? You want to be able to kayak? Okay, let's write a goal for that and physically make them write it down on paper. Write, the short-term steps to get there. Write the barriers that they're going to come up against and how they're planning to overcome them. And for me, that's something. Even if it's a physical, impairment that they might not overcome, a completely flaccid side or something like that. That doesn't mean their interest in that thing dies. But you have to help them find other ways to continue that interest or that hobby or that whatever it might be. And as I guess dropout rate, I find in the outpatient setting, if they're not going to complete their home program, the odds of them improving are quite low. I usually leave that up to them if they want to keep seeing me, or if coming back. I encourage them to take a 3-month break and come back and see me later or something like that. I try to keep tabs on those people, especially if they don't have any family support, and try to round back with them, 3 to 6 months later to see if they're interested in returning.
Did you speak last year at the conference? And your dad is the stroke survivor? I thought I recognized you. Yeah. Is it memory? Is it like a cognitive, do you feel like it's a cognitive barrier, or, because he's obviously not in a vegetative state. So he's motivated, is there any, even just the smallest thing that you could say, oh, when he sees our dog, he lights up, and that motivates him?
Yeah, small things, yes,
So,
decreased over
maybe
time.
I would look for like even the most, it barely is a tick off the radar, but putting the dog in his lap and getting him to use that other hand to pet the dog or engaging it, you kind of might be at that place. And then what was the second question? Was it about plateauing or kind of a maintenance program?
Yeah, how do you keep motivation when you don't ever see improvement? You're just having to continue to do therapies to not lose.
So again, I would say you take your bar down really low, and I mean you, because if he doesn't have a lot that's motivating him, and that's kind of a hard thing for us as therapists, because we want them to do it all and do everything, but we talked about, even though it's not the first thing we do, but then we're kind of looking at those compensatory strategies and ways to do that. And sometimes it's hard to find the thing, but there's a little thing. There's got to be a little thing that gets them going. And I don't know if you have anything else to add about that.
Yeah, so I think that one piece that we are neglecting to understand is their education and their level of comprehension and understanding. I think when somebody's had a stroke, they've had a lot of information thrown at them in a very short period of time, and compounded by memory impairments and underlying things that might be going on cognitively. I think that really having a conversation with them that's more focused on the person asking questions and gleaning from them their level of understanding. I think that what's really happening with a lot of these cases, or people not really biting in, is they don't have a really good understanding of what's going on. They don't have a realistic time frame of how life should be looking, and they're just not overall grasping the gravity of what's happening to them. And we think they are, because they've been given nothing but information since day one. So they have to get it, right? I mean, when I use bilateral integration, that makes sense to the average person, right? So I think that we need to really be mindful of how we're talking to someone. Are we talking at them, or are we talking to them? Is this a conversation, or are we constantly right now, this is not a conversation, I'm just talking at you, right? So I think that that's a big piece, is that we're really neglecting the gravity of understanding their education and comprehension. And so step one, we need to figure out where they're at with that. And then I think the other thing for them is, how can they themselves measure how they're progressing? I love that concept of the time walk. So in what way could they have a tangible goal that they can measure that they've accomplished and be completely independent with that? Because if their whole plan of care is dependent on professionals coming into their life, then there's not gonna be long-term carryover. So they need to be really biting into the whole process of their recovery and being as independent as possible with that process. So I just think that, to me, off the top of my head, I could see easy things like a goal journal, where they're keeping track of what they're doing independently for the day and actually measuring what they're doing and how that's growing. I think that people take for granted all the little ways they're making huge improvements, and they just don't see it. So how can we really have them grasp that? And so for us as therapists, we measure everything, and then we're like, oh my gosh, you just did this 9-hole peg assessment, and in 2 weeks you improved by 2 minutes. Do you have any idea how huge that is? And really having them see those small things that they are gaining on that otherwise they wouldn't even recognize or see. That's my answer.
Thank you.
Thank you. I think in regards to your last slide, more terms of a speech language pathologist, do you have a screener for anything about the awareness or level of concern about their home responsibilities, or do you just have specific questions you ask?
When I'm writing my note, I call it skilled discussion.
Okay.
Right? I'm sure there are, I guess I work in both inpatient and outpatient, so I think as far as inpatient's concerned, if I come in with like a piece of paper and I'm like writing things down, you kind of see that like shutdown, like, and I mean, it's not to say that I don't, I can't think of one right off the top of my head. I think this is where that, kind of dynamic assessment comes into place. But truly just being, okay, like, so when you leave here, what pharmacy are you stopping by on the way home to get your medications? And if they're like, oh, like that's something you should be thinking about. And I think just gauging their awareness in that way. Hopefully it's not the first time you've worked with them. Hopefully you've done some at least cognitive screening, if not more full-blown assessment, and you kind of have an idea as well. But, or sometimes I'll just, say, oh, hey, why don't you call ahead to your pharmacist and let them know what time you'll be there to pick up, your meds. And if that's like mind-blowing, that's a good sign. Or if like because you just talked to the OT that they're not safe to cook, but they're planning on cooking like a pot roast that night, that's a good sign as well. I know what you're asking, and I wish there was something off the top of my head, but truly I've found that to be the most useful thing, is this more like, I'm so excited you're going home, make sure you do these things on the way, and then that just gives you a lot of information about where they're at. Oftentimes it also comes from family, right? The person's like, they just called me and said this, and I'm really concerned about the fact that they think that they can do that or whatever.
I will just add, we're pretty lucky in our facility. We do a lot of home trainings too, and community reintegration activities. So it is very eye-opening, and I'm looking at Elizabeth because I swear she goes on every crazy home training. But we get to see a lot when they're in their environment and actually have them physically practice those real life things. Oh, let's get your mail and look at your bills, and what about X, Y, and Z? Where do you keep your medications? Those sorts of things. So we kind of get super involved in their life in that way, and then do real life practical things. If they let us, we'll let them even log in with us on their computer while in the inpatient rehab facility and see how they can navigate. So it's not just some scenario we're making up for them.
Yeah, sure.
Hi. Do you ever see anybody that's maybe a year, 2 years, 5 years post-stroke benefiting from maybe another stint at inpatient rehab to help maybe jumpstart their motivation or get them on the right track to learn new skills?
Yes. So we have had that happen, and we do see a lot of benefit from that. So it's just needing clinical need and meeting the requirements to do a readmission too, but we have had that in the past and seen significant benefit from doing that. And then also being very involved in a really interdisciplinary outpatient program, because there's times where those moments come and the therapists are the ones that flag it of, man, this person would really benefit if we could get them back into rehab and really start to hone in on where we're seeing some really amazing gains. So I guess, yes, we have seen that, and it has happened, and it's been very beneficial.
And not to be a Debbie Downer, but it always comes down to payer too, which is something we come up against, and now that I'm in more of an administrative role, getting that admission criteria, and sometimes it'll require like an acute medical stay if they have a UTI that really, wreaks havoc on their system, and they get admitted, and then that allows us, we do direct admissions, but it's getting harder and harder for insurance companies to approve inpatient rehab stays, even a person post-stroke, which is really sad. So it's just one consideration.
Hi. I'm an occupational therapist. I've worked at a lot of different skilled nursing facilities. Some of the really good ones will have like a physiatrist come, but then some of the other ones just have like an attending physician that, sometimes you don't really see that often. But my question is, do you all refer to any specialists, neurologist, physiatrist? I always hear there's like a shortage, so I was just curious how that looks for you guys.
Yeah, we do. So we're fortunate enough, we have a full-time physiatrist as our medical director. So she rounds and sees on the patients in the acute setting, inpatient, does a little bit of outpatient. We definitely refer to neurology. We have 2 in-house now at Benefice, which is great. And then we do some teleneuro as well. And actually, Erin, our stroke coordinator, is here from Benefice, and she works really closely with our teleneuro group. We refer out to psychology too. As well. And was there another subgroup you asked about?
Oh, I was just curious about which specialists, and I know like there's a shortage, but it sounds like you all
There
have.
is a shortage. I mean, we need more, but we're fortunate to have one. So we're actively recruiting. We're actually, a nurse practitioner is starting and is going to do some more of that physical medicine and rehab type work for us, which will be great. And we're going to try to get her more in the acute setting so we can kind of start these discussions and making sure that these people are getting to the right setting when they're in the acute setting, and kind of maximize as soon as we can on their care needs.
Thank you.
We do have an online question for Jessica. Says, with the increased prevalence of stroke patients' status post-COVID infections, do you have any specific or different recommendations or standards for this particular population of strokes?
I don't think anything different, but now you've just kind of added a layer of complexity. But again, I would look at those stroke risk factors too in my treatment program, and we do that as an interdisciplinary team, I think, pretty well, because we have the medical management. Plus, we're starting a home exercise program. We're making sure their medications, their diabetes is managed, because as we know, COVID also wreaks havoc on those types of populations with out of control diabetes, hypertension, heart disease. It's the same population. So they're just at risk for developing, stroke as they were for developing COVID-19. So I would just say modifying risk factors as much as we can while doing the rehab portion. So kind of that holistic approach to their care.
Is there any more? Oh.
One more, and then we'll let you off the stage.
I just have a question.
This is good.
So it's not basically for the stroke patient, it's for the caregiver?
Yeah.
So in our situation, we have been dealing with a stroke for a year. So we did inpatient for a month at Logan Health. When we first got my dad to Logan Health, we weren't even sure how to commute him. He couldn't sit up. He couldn't balance. He had complete paralysis on the left side. He was on liquids, or the thickening stuff. When we got to Logan Health, they did the same thing. No thickening, let's see where he is. By the time he left, he was able to get into the car and go up. So my question is, so my mom works, and she only works a couple days a week. She has in-home cameras so that she can watch him at all times. But how do you teach the caregiver to let them try, let them be? I know that she sometimes is afraid, like right now, they just planted all these gardens and he wants to go out and water, and she's like, well, why don't you wait till I get home? Or I'm gonna try walking to the bathroom instead of using my wheelchair, and she's like, oh, why don't you wait till I get home? There is an inhibit there as the caregiver. How do you train the caregiver to just, and he's afraid to fall. He fell quite a few, and it's always with me. I do not know what. I swear, he just wants me to look bad. But how do you teach him? How do you let them let go and allow them to get their independence back?
What's hard is we kind of put the fear of God in them right after stroke because we don't want them to fall. And so that is something on us. I would say we do that at our facility too. Like, we don't want them to become more injured. And so it is that balance of when do you allow them, like a little kid, you got to try or else you're not going to be okay. So what I would say is start small. Give him a small task during the day that you guys are okay with letting him do independently. And if he is fearful in the bathroom, if he's getting home health therapies, I would say our goal is for him not to be fearful in the bathroom. Work that out first, and then let him start going. Maybe just pick that one thing and do it, repetition, kind of that neuroplastic thing, that down-regulating of the fear of doing an activity. And I would say start there. But this far post-stroke, I think we kind of, and it might be easier on your mom or you to just pick one or two things at first that you give them independence at, and then expand from there.
I actually just saw some really amazing growth in a patient. So I'm blessed to do inpatient and outpatient at this point in time. So I had a patient that was inpatient, and we sent him home, high fall risk, contact guard for everything. You need to be right there because we need to see how they're going to do transitioning to home. And now that I have the benefit of having them as an outpatient, they've already done home health. And in the 1 week that I've been an outpatient and done goal setting and had a conversation with the caregiver and the patient, she went from contact guard assist to everything to walking around the house by herself in 1 week. And the hugest buy-in was the caregiver being involved in the therapy sessions and actually witnessing with their own eyes how well this person's doing. I think that people don't really grasp the gravity of contact guard assist. You actually hinder somebody fully recovering with their balance if you're always hanging on to them. They never actually get to learn their own balance in space if somebody's always providing some level of support or stabilization. So I think that it's really having that understanding of the transition from contact guard to standby assist, which happens when you empower them to let go and just be close. There's some really neat new designs of gait belts where they actually have handles on them and you can just buckle them. I love that for the home environment because then that can actually give the caregiver a little bit of security of, okay, I can be right here and not hang on, but if I need to grab, I'm able to do that very easily and safely. So I do love the new designs of some of these gait belts. It's actually really hard to give a standby assist and then hook in and grab the gait belt in time to correct a loss of balance. So I would encourage that. And I would encourage that the caregivers really be involved in therapy, which is really hard because a lot of caregivers are burnt out. They look at therapy as their break time and they finally get to do something that's not always being a caregiver. So I think that the biggest thing is maybe really working with that therapist and maybe having a scheduled time for an outpatient session where it's 100% focused on caregiver training and empowering both of them to maximize independence. So I think that being caregiver involved in the therapy is huge and doing it with a balance because the caregiver should not have to be there all the time, every day, all day. They need a break. But when they come to us, we have OT, PT, and speech for outpatient back to back to back. So for once or twice every 2 weeks, they could come in and caregiver is fully involved and the focus of the session for that day with all disciplines is caregiver training. It's really helpful.
The other thing is we teach fall training and we realize patients are going to fall or lose their balance. And I would say maybe a safe place for your dad if he wants to garden, if he's on all fours, but he loses his balance, it's okay. He's probably not going to be severely injured, but we train them how to correct that. That's also knowledge of performance. I think that's the right neuroplastic technique. They're going to make an error, and actually they'll learn how to correct from that error, and it's okay. He's in a safe environment. He's kneeling to do some guarding, but it was just a loss of balance. He got it back, and that actually will help him feel successful in something that he enjoys.